Welcome to the Deep Dive. Today we're jumping into a really important topic, gestational diabetes. We're working from some excellent revision notes you've shared, aimed at conditions often seen in exams like the MSRA, or GOAL. Simple. Take these notes, cut through the noise, and give you the high-yield essentials. Everything from definition to complications. Basically a clear pathway for revision or just understanding. Okay, let's unpack this. Gestational diabetes. First off, what exactly is it?
Right. So put simply, it's diabetes that starts during pregnancy. The main thing is high blood sugar levels that, weren't there before the pregnancy. And crucially, it's usually temporary, typically resolves after the baby is born. That's a key point.
Temporary. Okay.
But common.
Yeah, pretty common. It affects about 1 in 20 pregnancies, something like 4% globally. And here in the UK, too, it's actually the second most common medical issue in pregnancy. But, and this is really important, even though it often goes away, having GDM significantly bumps up a woman's risk of getting type 2 diabetes later on. It's a warning sign for the future, you could say. Wow, okay. Temporary condition, long-term shadow. Got it.
Mm.
And how do doctors actually pin it down? Is there a specific test?
Yes, definitely. There are standard criteria. It usually involves an oral glucose tolerance test, or OGTT. You're looking for specific blood sugar levels. So a fasting plasma glucose of 5.6 millimoles per liter or more, or after the sugary drink, a 2-hour level of 7.8 millimoles per liter or more.
5.6 fasting, 7.8 at 2 hours.
Yeah.
Those numbers are the diagnostic line in the sand.
Exactly. Those are the NICC criteria thresholds.
Okay. Diabetes starting in pregnancy, usually temporary, ups future risk. Diagnosed with OGTT using 5.6 or 7.8. But why? Why does pregnancy itself cause this?
The why. That's really interesting. It boils down to hormones from the placenta.
The placenta.
The placenta makes hormones that are vital for the baby, of course, but some of these hormones actually interfere with the mother's insulin. They block its action, essentially. We call this insulin resistance. Now, insulin normally helps sugar get from the blood into cells for energy. With this resistance, insulin just doesn't work as well.
So the body tries to compensate.
Exactly. The pancreas tries to pump out more insulin, but in women who develop gestational diabetes, their pancreas just can't make enough extra insulin to overcome that resistance caused by the pregnancy hormones. So the result is glucose building up in the blood, high blood sugar.
Ah, okay. So it's like the demand caused by the hormones outstrips the pancreas's supply of extra insulin. Makes sense. But not everyone gets it. So who's more at risk?
Good question. There are several well-known risk factors. A big one is weight before pregnancy, being overweight or obese.
How much overweight?
Specifically, a BMI body mass index over 30, that increases the risk more than threefold. It's a major factor. Then there's family history. If a close relative, like a parent or sibling, has diabetes, the risk goes up.
Right.
And like we mentioned, if you've had gestational diabetes before, your chances of getting it again are pretty high, around 50%.
Okay, so previous GDM is a strong predictor. What else?
Well, conditions like polycystic ovary syndrome, PCOS, age is another one, being over 25 increases risk, and ethnicity plays a role. Higher rates are seen in people with South Asian, Black, Middle Eastern, Asian, African American, Hispanic, Latino American, or Pima Indian backgrounds.
Okay, those seem like the core ones. But the notes mention some others too, things that might be less obvious.
Yes, definitely. Some perhaps less common ones, but still important. Like having previously delivered a large baby, what we call macrosomic, that's defined as 4.5 kilograms or more, about 9 pounds, 15 ounces.
4.5 kilos, that's a specific number to remember.
It is. Also, gaining significant weight between pregnancies, like more than 3 BMI units, or having pregnancies close together a short interval. And sadly, having had a previous unexplained stillbirth is also linked.
Right. And one more really striking one you mentioned.
Smoking. The notes say smoking doubles the risk of gestational diabetes.
Doubles of the risk. Wow. Okay, that's a long list. For revision, maybe grouping helps, like weight and lifestyle, personal history, family history, demographics like age and ethnicity.
That's a good way to think about it. And locking in those numbers, BMI 30, baby 4.5 kilograms, is helpful.
Got it. So we know who's more likely to get it. How common is it overall? You mentioned the 1 in 20 figure earlier.
Yeah, that's about right. Around 4 or 5% in the UK, maybe 2-5% globally. And these numbers are kind of going up, linked to the rise in obesity worldwide.
Which ties back to obesity being a major risk factor.
Exactly, it connects. And it's worth remembering the extra challenges in lower-income countries. Sometimes less awareness, fewer resources, but potentially high rates.
Right, the bigger picture. Okay, how common Now, what does it actually feel like? Are there obvious symptoms?
This is so important. Very often there are no symptoms at all. None. Many women feel perfectly normal.
Which is why screening is crucial, I guess.
Absolutely, because you often can't rely on symptoms. But if symptoms do show up, they're the classic signs of high blood sugar.
Like what?
Things like being much thirstier than usual, needing to pee more often, feeling really tired or weak, sometimes blurred vision, or getting infections more easily, like UTIs. But again, emphasis on often asymptomatic.
Okay, so usually silent, which leads us back to testing. How do we actually find it then, in practice?
Right, how do we
Yep.
catch it? Well, it relies heavily on screening those at risk. Women with risk factors usually get offered testing early, maybe at their first booking appointment. Also, routine checks during pregnancy sometimes pick up sugar in the urine glycosuria. If it's 2+ on one test or 1+ on two separate tests, that usually triggers the proper diagnostic test.
Which is the OGTT we talked about.
Exactly. The 2-hour 75-gram oral glucose tolerance test. That's the gold standard for diagnosis.
And the timing for that. You mentioned 24 to 28 weeks.
Yeah, that's the standard window. Between 24 and 28 weeks gestation, that's when those placental hormones really ramp up the insulin resistance, so it's the best time to see if the body's coping.
Makes sense. What about women who've had GDM before?
Ah, good point. They get tested much earlier, right at the start at booking. If that first test is normal, they still get tested again in that 24, 28-week window because it can develop later.
Okay. And other risk factors just get the 24, 28-week test.
Generally, yes. The process involves fasting, having a blood test, drinking the glucose drink, then waiting 2 hours for a final blood test. And again, those magic numbers, fasting 5.6 or more, or the 2-hour result 7.8 or more, that confirms gestational diabetes. Other tests like random glucose or HbA1c exist, but the OGTT is really the main diagnostic tool here.
Got it. OGTT, 24, 28 weeks, 5.6, 7.8. Key takeaways. Now, if someone does have high blood sugar in pregnancy, is it always gestational diabetes? Could it be something else?
Yes, it could. The main thing to differentiate it from is pre-existing diabetes type 1 or type 2 that maybe just wasn't diagnosed before the pregnancy.
Ah, so uncovering diabetes that was already there.
Exactly. Making that distinction is important mainly for long-term management after the pregnancy, although controlling blood sugar during pregnancy is vital whatever the type.
Okay, so let's say the diagnosis is gestational diabetes. What happens next? What's the management plan?
Right. Management is all about keeping blood glucose in a tight, safe range for mom and baby. The first step is always lifestyle.
Diet and exercise.
Yep, a balanced diet, paying close attention to carbohydrates, spreading them out, choosing lower GI options, and regular physical activity that helps the body use insulin better. Then, crucial part, self-monitoring. Women learn to check their own blood sugar levels several times a day using a finger prick test.
And there are specific targets they're aiming for.
Yes, very specific targets. These are important to remember. Fasting levels should be 5.3 mmol or less.
5.3 fasting, lower than the diagnostic threshold.
Correct. Then, 1 hour after starting a meal, the target is 7.8 millimol or less.
6.4 at 2 hours.
Yeah.
5.3, 7.8, 6.4. Those are the management goals.
Precisely. If diet and exercise aren't enough to hit those targets consistently, then medication is needed.
What kind of medication?
Often it's insulin therapy. Metformin is sometimes used too, but insulin is very common and effective. Women diagnosed are usually seen quickly, within about a week, in a specialist joint diabetes and antenatal clinic. Management also involves planning the birth timing, mode of delivery, and monitoring the baby's growth closely.
And after the birth.
Postpartum care is key. The medication, if used, is usually stopped straight away, but then the focus shifts to lifestyle advice to reduce that future type 2 risk. And importantly, regular follow-up testing, usually an annual blood test to screen for developing diabetes.
So it's ongoing vigilance, really.
Right.
What's the overall outlook then, the prognosis for mother and baby?
Well, the risks involved are similar to other types of diabetes in pregnancy, mostly linked to the baby potentially being large. But here's the positive. Treatment works.
How effective is it?
Very effective at reducing some key risks. Managing GDM significantly lowers the chance of having a very large baby, macrosomia. It reduces the risk of preeclampsia for the mother, and it lowers the chance of shoulder dystocia during birth.
That's good news. Reduces the big, immediate problems.
Yes. But, and this is a really interesting nuance from the research, treatment doesn't seem to make a big difference to the baby's risk of having low blood sugar right after birth, neonatal hypoglycemia, or their long-term metabolic health, like obesity risk, once you account for birth size.
Oh, really? So it fixes the immediate delivery issues? Mostly, but maybe not all the metabolic stuff for the baby.
That seems to be the complex picture, yes. It suggests there's more going on than just the glucose level itself during pregnancy affecting those outcomes.
Fascinating. And for the mother long term?
Well, blood sugar usually normalizes postpartum, but that 50% recurrence risk in future pregnancies is real. And the increased risk isn't just type 2 diabetes and metabolic syndrome. There's also a higher risk of coronary heart disease later on, even if she doesn't develop type 2.
Right, and the child.
The child born to a mother with GDM does have a higher chance of developing obesity later in life.
Okay, so impacts across the board, short and long term. Let's be explicit about the complications if it's not well managed. What can go wrong?
Sure. For the baby, the main issues stem from that high glucose exposure. Macrosomia, the large baby, which increases risks during delivery like shoulder dystocia, bone fractures, nerve injuries. Then neonatal hypoglycemia, the low blood sugar after birth because their own insulin production was ramped up, being born large for gestational age. Sadly, an increased risk of perinatal mortality, too.
And longer term to the child.
Longer term, potentially issues with glucose tolerance, that higher risk of obesity we mentioned, and maybe even impacts on intellectual development, though that's still being studied closely. For the mother, during pregnancy, the big risk is preeclampsia. And long term, the major one, as we've stressed, is that significantly higher risk of type 2 diabetes down the line.
It really highlights why catching it and managing it is so vital. Okay, so let's try and pull this all together for you. We've dived into gestational diabetes using these revision notes. We know what it is, pregnancy-induced high blood sugar, usually temporary, diagnosed with an OGTT, those numbers 5.6, 7.8. We know why it happens, placental hormones causing insulin resistance that the body can't quite overcome. We know who's at higher risk, BMI over 30, family history, previous GDM, ethnicity, age over 25, previous large baby over 4.5 kilograms, smoking. Lots to remember there.
Yeah, grouping them helps.
Definitely. And we know screening, OGTT at 24, 28 weeks, is key because it's often silent. Management starts with lifestyle, then monitoring targets 5.3, 7.8, 6.4, then potentially medication like insulin.
That's the core pathway.
And the outcomes. Management really helps reduce big risks like macrosomia and preeclampsia, which is great, but maybe doesn't fix everything, like neonatal hypoglycemia or some long-term child health risks. It's complex.
It is.
Hopefully breaking it down like this helps make it stick for revision.
Absolutely. And maybe a final thought to leave you with, sort of building on that complexity. Consider this. The fact that our current treatments are good for preventing macrosomia and preeclampsia, but not so much for neonatal hypoglycemia or, seemingly, the child's long-term metabolic future. Well, it really highlights that maybe simply controlling the mother's glucose during that pregnancy window isn't the whole story. There might be deeper developmental programming effects, or maybe interventions need to start earlier or differently. It points to areas where we still need more understanding.
That's a really thought-provoking point. It's not just about hitting the numbers during those months. Okay, that wraps up our deep dive on gestational diabetes for today. A huge thank you for bringing your source material and tuning in. We hope this breakdown has been really helpful for you. Keep exploring, keep consolidating that knowledge. And specifically, if you are prepping for the MSRA, you might want to check out pastmsra.com and also freemsra.com for more resources. Thanks for joining us, and we'll catch you on the next deep dive.